Hi, this is Bob Schmidt. I'm one of the medical directors at ARUP Laboratories. I'm here to discuss how to estimate the impact of changing laboratory methods. This is a problem we all face, and we've come up with some interesting approaches to this that I'd like to share with you. I haven't done this alone. I've worked with a bunch of people on this project. Dina Green from Kaiser Permanente, Austin Adams, Jonathan Gensen, Jolie Straczewski, and Chris Lehman from ARUP, and Mike Ricordi from the Department of Mathematics at the University of Utah. So when we think about changing to a new method, there's various outcomes that can happen. One is we can have differences in accuracy, so we can have measurement error, and the other is there can be cost implications, either through operations or just the direct costs of the test itself. So we're going to explore these and use a specific example of how to approach this kind of a problem. We're going to look at a very special kind of problem where we're looking at accuracy around a specific decision limit. Okay, so the example we're going to look at is creatinine measurement. You can see here there's two main methods that are used to measure creatinine. There's the Jaffe method and the enzymatic method. At our laboratory, we currently use the enzymatic method, and it costs about $2 per test. There's the Jaffe method is used most widely in the US. About 70% of labs use the Jaffe method. It's quite a bit less expensive, so there's a $1.70 savings per test, and that can add up because this is a frequently ordered test, and we estimate we could save a couple $100,000 a year if we were to switch from the enzymatic method to the Jaffe method. And there's other problems, though. The Jaffe method is subject to more interferences than the enzymatic method, and the magnitude of the interferences are greater in the Jaffe method than the enzymatic method. So you can see there's a bit of a trade-off here between cost savings and accuracy. And we're going to explore how to really evaluate that in a cost-effectiveness analysis using this example. So the usual kind of thing you'll do is make a Bland-Altman plot where you look at the difference between different results. You get a bunch of samples, measure them by both methods, look at the difference between them, and plot it against the average. And that tells you whether there's bias on average between the two methods. But this really doesn't help us much in terms of the decision problem that we're facing with creatinine. Because when we look at creatinine, what it's really used for is to calculate estimated GFRs. And the GFR is the glomerular filtration rate, which is used to evaluate kidney function. You can see the nephrologists have these categories based on GFRs of kidney disease. So if you're down below a GFR of 15, you have kidney failure. If you're above 90, you're considered fine and healthy, and there's all these different gradations in between. So the problem then with accuracy here with creatinine and then subsequently eGFRs is that we might misclassify patients as to mild or severe disease and so on. And we have to think about the implications of that in addition to the cost savings. So we look at our hospital. Here's the distribution of serum creatinines in the upper panel. You can see it goes from about 0.5 milligrams to deciliter up to about 2. And then when you do the calculations and turn those into eGFRs, you can see the distribution there. And this is the equation that's used to convert those. This is the CKD epi equation. Just the bottom line here, it's a sort of a complicated equation, but serum creatinine values are the input. You crank through this equation and you come out on the other side and you get the eGFR that's used to evaluate kidney function. And if we look at the relationship then between eGFRs and serum creatinines, it's shown here. And that's sort of the well-known hockey stick kind of graph that you see between these two values. So what happens? What's the effect of imprecision? So we looked at there was differences in precision between the Jaffe method and the enzymatic method. So if we have high values of serum creatinine, which is shown on the horizontal axis, and there's some variation in the input, you can see that there'll be very small variations in the eGFR. So it's very stable at that particular point. On the other hand, if we go down where there's low serum creatinine levels and we have some variation in the input, there'll be huge variations in the output in eGFR. So imprecision in our measurements will have different effects depending on which patients we're looking at. So when we do those kinds of calculations and look at the standard deviation of the estimated GFR as a function of the estimated GFR, you can see that it increases at the higher values, just like we showed. But these are going through calculations showing exactly what the imprecision in the eGFR would be, depending on the imprecision in the serum creatinine. So when we look at Bland-Altman plots for the eGFR, you can see there's quite a bit of scatter, quite a bit of uncertainty, resulting from a fairly small amount of uncertainty in the serum creatinine, and it's particularly high. The bias is particularly high at the higher levels of eGFR, just as we showed on the earlier graph. But now what we're really interested in are what are the discordances at the particular decision limits. So the important decision limits, as I showed you before, are at 60 mils per minute, 45, 30, and 15. These are the limits that the nephrologists use to classify patients. And I've shown the discordances that we found out of 550 patients comparing the Jaffe method and the enzymatic method. So the upper panel shows eGFRs by the CKD epi method. Every one of those arrows is a discordance, and it's showing the enzymatic method pointing towards the Jaffe result. So the top one there, you can see under the CKD epi, under 60, you can see that the enzymatic result was, I don't know, about 63, and the Jaffe result was about 58. So it spans that width there. So we have a whole bunch of those, and then the question becomes, why are we getting these discordances? Is it due to bias? We know that the Jaffe method suffers from bias. Or is it due to just imprecision? And we also know that if we were just to repeat measurements of the enzymatic method, the most accurate one, we would still get discordances just because of the imprecision in the enzymatic method. So how much of this can we blame on the Jaffe method? So the exercise we went through is assigning blame to methods. Okay? And that's sort of a new thing that I don't think we've seen done before. So we looked at the overall discordance rate here. Okay, so just the number of arrows that we had on those diagrams that I showed you before. So we just count those up and divide by the number of samples we have. So there was about 3% of the samples had discordances at the 60 mil per minute rate, so on and so forth. So overall, we'd expect about 5 out of 100 samples to have some form of discordance. 60 mils, let's just look at that. Once again, the question comes up, why are these arising? Is it due to imprecision? Is it due to bias? What part of this is due to the Jaffe method? What part is due to the enzymatic method? Where can we place the blame? So how does discordance due to imprecision arise? Well, if we look at this graph, we could get discordance two different ways. So in scenario 1, the first measurement could be above 60, and the second measurement could be below 60. Then the other way around in scenario 2. So this is just repeating two measurements by one method and looking at the ways we could get discordance. So the overall probability of that happening is just the area under the graph that I have shaded there in each scenario. So how did we evaluate this? What we wanted to do was estimate what the discordance rate would be of just if we were to repeat methods with our best available method, with the enzymatic method. How many discordances would we get? And when we subtract that away, then we could place the rest of the blame on the Jaffe method. So that's what we did. So the way we did this is we looked at the probability of discordance given that you are at some particular eGFR level. So that's shown here. So the red spike there in the graph, that's the distribution of GFRs we have. If we just pick particular one, like 58, then we go, what's the probability that if you had a GFR of 58, that you would have a discordant measurement? And then you look at the probability of having a GFR of 58, you multiply those two things together, that tells you the probability of discordance and having a eGFR of 58. Now if you repeat that over every GFR level, that gives you the overall probability of having any discordance, and that's what's shown in the equation down at the bottom. The idea is pretty simple, but the mathematics gets kind of complicated. Okay, so now we look at the components of discordance. And what I've listed up there is the discordance rate that's observed between the enzymatic and Jaffe method. That was the totals that I showed you in the table before, about 5%. What I've got over on the right is the discordance rate if I was to repeat the enzymatic method over and over again. And that's just due to imprecision. And then the difference between them is what you might call the attributable risk of discordance that we could attribute to the Jaffe method, just subtracting that away. And even better, we can do similar kinds of calculations to find what the discordance rate would be if we were to, just due to imprecision alone, if there were no bias in the world at all, what it would be if we compare the enzymatic and Jaffe method. And that's the one shown in the middle, the DR due to imprecision for the enzymatic and Jaffe method. So now we can divide up the attributable risk of discordance to imprecision and bias. So we have the total risk, risk due to imprecision, and risk due to bias. So now looking back at this, we're going to look at what components of these discordances arise from these different causes. So just looking at this table, we found out that at each different level, there's these observed discordance rates, and now we have the attributable risk in the bottom lines. That's about 3 out of 100 on average is due to the Jaffe method when we do these plots of each one against each other. None of it's due to precision, that's just spare change, and most of it's due to bias and interferences, which we would have expected because we know the Jaffe method. But now we can estimate if we were to switch from the enzymatic method to the Jaffe method, we'd see on average about 3 out of 100 more misclassifications than we would have with the enzymatic method. So now we can look at the incremental impact of a change in method relative to this particular decision limit. So now let's look at how we could use this in a cost-effectiveness kind of calculation. So the incremental cost-effectiveness ratio, the ICER, is just the change in cost of the change in outcome if we have two different methods we're comparing. And we showed that the cost difference was $1.70, and we see a change in misclassifications of about 3%. This turns out to be $51 per misclassification prevented. So the question is that worth it? And that's a hard question. But anyway, I think this just illustrates the way you can use this method to evaluate that. Now we know there'll be more misclassifications. We know how much money we save, and so on. So, if it was $1 million per misclassification, it would be an easy decision. If it was, 5 cents per misclassification, it would be an easy decision. And this is sort of somewhere between. Okay, so let's just summarize what we've done here. So starting at the left, our target here was to get some sort of cost-effectiveness calculation. And we did that starting at the left by getting the precision of the measurement that we were interested in and the distribution of results for that measurement. We used those to find the expected discordance, eliminating all sources of bias. So that's the expected discordance in the middle. Then we compared the expected discordance and the observed discordance to get what we call the attributable discordance. That's the blame we can place on one of the methods. And then, taking the attributable discordance and the cost, we came up with the cost-effectiveness ratio. And I've not seen this done before. And we think it's sort of a useful technique for evaluating a change in method. So now that we've evaluated cost-effectiveness, let's take one more step back. Overall, what we're doing is a risk assessment. And this is a much broader assessment than what we've looked at already. So there's a savings to the lab if we do this. And we can also evaluate the probability of a misclassification. And those are all internal things to the laboratory. But what we really need to do is take a system view and look beyond the laboratory of the downstream consequences of any change we make. So a risk assessment involves two things. It involves the probability of the event and the consequence of the event. So you can imagine something that has very low probability of happening, but a severe consequence, say like a probability of 1 in a million, but the consequence is death, that would be considered risky. On the other hand, you could have something that has a high probability, maybe it happens 10% of the time, but the consequence is trivial, that would still be low risk. So we need to really think about the consequences in a global sense rather than just a narrow sense of like we've done here. So the study I've done has been pretty narrow, estimating the probability of a misclassification. And we've looked at part of the consequences, which are the cost consequences of this, and we've shown that we can save some money in the laboratory. But really, what would happen here? Well, once again, these misclassifications have impacts on patients, right? It can change monitoring, it can change treatment, it can change their insurance status if they get, that they have kidney disease on their medical record. So these are not trivial things. For example, one of the things that might happen is, as a consequence of a misclassification, somebody gets evaluated by a nephrologist, and so the system wouldn't necessarily save money. We save some money in the lab, but overall, nephrologist visits are expensive, and that might overall be more costly. So we're trying to evaluate that. At present, it looks like we're working with some nephrologists, and most of the time they just continue monitoring, and the consequences would be pretty benign. So we're evaluating whether we could use the Jaffe method. I don't think it's clear, but we're in those discussions with nephrologists. So just to summarize, we're evaluating a change in method here, and I think there's a couple things. One, we've shown a method by which we evaluate the probability of events, and I think that's new and can be widely applied. This is a problem that comes up a lot, and we have a method now where we can do that to go into a cost-effectiveness analysis. But I think maybe a larger method here is looking at the role of the laboratory and integrating these kinds of decisions downstream and looking at the overall system consequences of a change in laboratory method. That's a little more difficult, but it's important to do. And as I showed here, if you take a fairly narrow perspective, it's obviously savings to the laboratory and some advantages, but we do need to take a system perspective, but the laboratory can inform that. We can provide these probabilities. We can show analytically what's likely to occur if we were to change methods, and then engage with our clinical colleagues and decide whether the risk is worth it. Thank you very much.